Good afternoon or good evening, everyone. Welcome to our live Q&A with the expert focused on the best of UEG week of 2022. This activity is jointly provided by Global Education Group and Bonum CE in partnership with Monday Night IBD and the United European Gastroenterology. And it is supported by education grants from AVI and BMS. Please let us know where you are in the world by taking the poll on the screen. I'm Aline Charabaty. I'm the founder of Monday Night IBD. I'm the clinical director of the IBD Center at Johns Hopkins School of Medicine, Sibley Memorial Hospital. And I am joined today by my wonderful colleagues and friends from around the world. Dr. Iris Dotan, she's a chief of the Division of Gastroenterologists. She's the chief of the Division of Gastroenterology at Rabin Medical Center, and she's the chair of International Organization for the Study of IBD. Dr. Charles Murray, he's the department chair of Gastroenterology, Digestive Disease and Surgery Institute at the Cleveland Clinic in London. And Dr. Miguel Regueiro, he's professor and chair of Cleveland Clinic Digestive Disease and Surgery Institute. Iris, Charlie, and Miguel, welcome.
Thank you.
Good evening. Erev Tov.
Great to be here.
Thank you again for the wonderful webinar we had on Saturday. We had great feedback, a lot of amazing information that was shared. And we asked, our audience to send us questions. We got a few on Twitter, a few on Instagram, a few by DM. So I'm going to start with you, Iris, since I'm startling on your title for some reason. I think I'm so, I'm fangirling. I'm so impressed by you always. I wanted to do it right and I didn't. But now that we're here, you presented the result of the VEGA study that really showed that the combination therapy of two biologic, an anti-IL-23 and anti-TNF, was more effective in inducing clinical remission at the time of induction and during maintenance than either monotherapy alone. But bringing this amazing data to real life, how would we apply this in real life? When do you see yourself thinking, you know what, this patient with a new ulcerative colitis, bio-naive, needs two biologic to induce remission and increase their chance of maintaining remission at year one? Or is this something that we should think about for all our patients with moderate to severe UC?
Thank you, Aline, for the question. This is a very relevant question. And talking about best of UEG, this was discussed a lot during the session, where this is the longer term study, right? Because the first part of VEGA, which was sensational by itself, right, was the 12 weeks. This was the 38 weeks, where indeed the authors had shown that the combination of Goselkumab and Golimumab together were better than either one alone, and some of the outcomes were significantly better at 38 weeks. So you're right that the immediate question that was, first of all, and I'll start with the less scientific question, but the very practical, as you alluded to, okay, like who is going to pay for this and how can we do this? So to this we'll come back in the end, but I think that in a world that's going biosimilars, it is an important question at the moment, but it will not be that important soon. I think that the concept was very important. And the concept is that also in ulcerative colitis, a way of, it's not necessarily top down, but a way of combining your efforts is better than either one alone for these 38 weeks. So first of all, yes, you have an option to do combination. Now, what are the biomarkers and what are the predictors of the success of this combination? So again, a little asterisk. First, we need to see longer term outcomes, because ulcerative colitis is not a 38-week disease, but we always look at our patients for the shorter term. So if I need to conclude, I think that patients that look more severe according to our not very sophisticated clinical criteria at the moment, and if your patient has severe colitis, I'm sure that with the other options that we have today, we will consider combination biologics, in this case, Goselkumab and Golimumab, but the idea of an anti-TNF and IL-23, and then as the patient improves, this is another aspect of the study, you can withdraw one of them, and then we will see if this maintains indeed the good outcomes. So a patient with severe ulcers, I think on colonoscopy, a patient with a high CRP, because most of these patients don't raise their CRP. So if you have a high CRP, a patient that is not imminent colectomy, I think that these are the patients where we'll try to see if a combination is working, and also for the longer term.
Excellent. So maybe the next step is really the selection of these patients in the real world and see if that affect their long-term outcome.
And the use of biosimilars, and to try, of course, this concept, I'm sure that it will be attempted with other drugs from similar families.
Absolutely. Miguel and Charlie, you both presented studies looking at the fact that by prolonging therapy beyond the induction period, we can capture response in patients who didn't get worse during this induction but didn't get better. Charlie, you presented the data with Ozanimod. Miguel, you presented the data with risankizumab, or the other way around. It's been a while. But the question that came, and I think it's a very valid question, is: are we abandoning therapy too early? Are we assessing response to therapy too early? Is 10 to 12 week too early to judge if this drug is the right drug for the patient? And so my question to you: what do you do in your practice, and what are the lessons we need to learn from both of these studies that were presented? Which patient can we wait? Which patient should we switch? And again, to strike that right balance where we're not cycling through one biologic after the other and then we end up with nothing, but at the same time not keeping a patient a biologic or small molecule now, or we're not keeping the patient feeling sick or getting worse on an ineffective therapy. So maybe Charlie, you'll start, and then
sure.
Miguel.
So we all have slightly different experiences, don't we, all over the world with these drugs. But I think there's a lot to learn from looking at our rheumatological colleagues. So I think the rheumatologists look at us when we talk about dose optimization and immune modulation and concomitant therapies, and think we're crazy because they've always had many biologics, and they've always cycled through many biologics. And I think there are lessons to be learned there, that actually, as we get more and more of these different biologics and different availabilities, that we do need to be very sensible about how we use them. So Iris has just talked about combination therapy. We're experts in gastroenterology because we have had to learn over the last few years about how we use a drug to its maximal capability. Now, that doesn't mean treating people for many months, for years, inappropriately and inadequately. But there are groups of patients, especially outside, for example, the acute severe colitis, and certainly the Crohn's patients and to use that phrase we always use about the marathon or the sprint, that we are treating lifelong. And actually, it's really it's beholden on us to actually try as we can to make use of the drug to the best of our capability. And this data that we're presenting demonstrates that there are patients that will be effective for. Now, I think, first of all, we do no harm. I don't think there's anything to be gained by watching people get worse on medications. But patients will tell you whether they're getting worse on a medication. I think if they're static, if we have the imaging modalities and the biomarkers to tell us that they're not deteriorating, that's the patient group in which, with either of these medications, I would consider increasing the length of time of treatment. And we've both demonstrated, myself with risankizumab and I'll leave it to Miguel to talk about Ozanimod, that actually if you extend that treatment, you will give patients the ability to get better on a drug that may well have been thrown over for them if we cycle too quickly.
Absolutely. Miguel, again, your thoughts, and I was wondering, do you think that using biomarkers, maybe at the end of the induction period, seeing if there's any improvement or at least things are not getting worse, would that give you more of a push? Let me try this drug longer. What other criteria do you look for before extending therapy in a patient? And where should we stop and switch versus give a chance for the drug that we chose to work?
I think he made a very important point initially, is that we can't burn through our therapies. And I think we're all making variations on the theme point. And we've seen that many times where patients come in, they fail one after 2 months, they go to the other. And we know that they work less well. So the Ozanimod study that I presented in ulcerative colitis, looking at after the first 10 weeks of induction, continuing for an additional 10 weeks, and you saw a good pickup of a number of patients. So how do I apply that to my practice for both Crohn's and ulcerative colitis? And to your point, the ideal situation, and I usually tell my patient, almost regardless of the therapy, that I want to give them 3 months. So essentially 12 weeks to at least make sure they're not getting worse. Both you and Charlie made this point, and I think that's important. If a patient's deteriorating and getting significantly worse, that's different. But as long as they're stable and even slightly improved, then the question is the calprotectin improving or the CRP improving? Is there some sign of benefit? Remember too, for the audience, the way we define clinical outcomes in clinical trials is very different than our practices. So what may meet a clinical remission based on criteria in a clinical trial, we would see a patient in our clinics that maybe aren't in a clinical remission based on strict definitions, but they're actually getting better. And I think the bottom line is extending it for another period of time. I usually say give everybody 3 months, and then ideally give to 6 months, again, as long as they're not worsening and there's some improvement in their biomarkers. And then the final point I'll make that's not entirely based on the studies, but I also think we're evolving to a point where maybe we have in the past had scoped actually too soon and maybe waiting, especially in Crohn's, a little bit longer. So for example, I would always tell my patients at 6 months, I want to do a scope, whether it's ulcerative colitis or Crohn's. Now I'm wondering if their calprotectin's improved, their CRP's improving, they're feeling better. If I scope them at 6 months and see inflammation, am I really going to switch them from that therapy? Well, sometimes just simply waiting a little bit longer, scoping them at a year, as long as the biomarkers are improving, probably makes sense. And I think both Charlie's studies on risankizumab and Crohn's and mine on Ozanimod and ulcerative colitis really demonstrate that.
This is great, all great points that, managing IBD is not like speed dating. It's not quick results. Set realistic expectation. And I think that's so important for a patient to know when to expect to feel better. So there's, we're removing some of that anxiety. Is this working or not? And really we're becoming, it sounds like, more reasonable as we're aging in the understanding the IBD, that, there are certain things we can follow, that it takes time. It's more like a marathon, like Iris was saying. And so the idea is really to choose the right therapy. It's going to be effective and safe on the long run for the patient. And I really like the fact that Miguel, that you said it's important to talk to the patient, right? Sometimes it's very subtle that things are better, because sometimes we get into a situation where I'm still having diarrhea, but when you count the number, or maybe there's still diarrhea but no more urgency, now I can leave the house. So there's a lot of little things that can point that we're having some kind of response, we're not there yet, and that would give us a sense of let's continue the therapy longer and see if we have a full response and full remission. That's fantastic. Miguel, I'm going to stay with you because you presented the data on a study you were involved in, looking at patient-reported outcome and fatigue as a marker also of improvement in patient treated with mirikizumab. The question that I have for you, because fatigue is one of the symptoms that often patients bring up, and that's a very frustrating symptom. But what other symptom outside the GI symptoms, right? The abdominal pain, the blood in the stool, the diarrhea that we typically look at in randomized controlled trial. I think fatigue is an important endpoint. What other endpoint do you think, we should look at as an endpoint, or as part of how we're looking at the efficacy of neurotherapies and any therapy in IBD?
I think the point you're making is so important, that this is inflammatory bowel disease is a whole person disease. And what I mean by that is it's not just the gut, and it's not just the traditional extraintestinal manifestations that we know, arthritis, eye inflammation, liver, skin, kind of the traditional ones. Probably the extraintestinal manifestations include fatigue. We're now learning bowel urgency is a huge impact on patients' lives and livelihood and quality of life. Absenteeism and presenteeism, so missing work, missing school, or going to work and school, and presenteeism is just not being able to function, whether it's fatigue, distraction, going to the bathroom. Sleep is another big factor. Even independent of fatigue, we've learned that probably from cytokine profiles and immune-mediated diseases, yes, getting up at night to have a bowel movement, but even sleep disturbance is independent of bowel movement. So I think the point you're touching on, and one other one I wanted to make, is sexual dysfunction, which is something that we don't often ask. The patients obviously sometimes won't bring it up, and we won't ask the question. But in some surveys, when you ask these questions, 2/3 of patients are impacted by many of these different symptoms. And I think in the future, we're going to see more holistic approaches to symptoms in our clinical trials. The problem has become their subjectivity, and it's hard in a clinical trial to always measure. But I think now the reality is we're there, and we're going to ask these more in clinical trials and in our practices.
You know,
Here,
Ellen, if I
that's
may,
okay.
I
Yeah.
think that what you're saying, Miguel, is so important, and you should be applauded, of course, and you were for these studies. And actually, I think that it goes immediately to clinical practice, where we learn that if you ask, and that's the last thing that you said, if we don't ask about fatigue, or worse, if a patient says, I'm tired, and I'm sure all of us heard from some of the more senior faculty when we were students, oh, everyone is tired, or you're young, why won't you be tired, right? You're young, you're dating, you're going out. No, so patients are tired and fatigued. It's not the same, right? Even when they sleep enough, and sometimes they don't sleep enough. So if you don't ask, you'll never know. And if you ask, so it's hard to quantitate, but by studies like yours, so we see what are the questionnaires that you can ask. Can you use an IBD disc? Can you use a fatigue questionnaire? There are multiple of those. And you use whatever is possible, but at least you know, and the more we will use them, the more we will do studies on them. And I'm sure that we will see that this is a huge problem, much bigger than having one or less bowel movement.
Absolutely. Thank you both for reminding everyone and all of us that IBD is not only a GI disorder. It's really affect people's life at so many different levels. And so just by asking someone, are you doing okay? The first answer is going to be yes. If we don't ask the questions, we're not going to get the answer. And we as physician, nurses, clinician have to be the one asking. And we have to be comfortable asking about fatigue and urgency and incontinence and having to wear diapers and missing days of work and sexual activity and social psychosocial life that's disrupted. And I think it's very important for us to become comfortable asking these questions. They are very intimate questions, but who else is the patient going to talk to, right? The patients with IBD are seeing their GI doctor more than anybody else, unfortunately. And I think it's upon us to really open that conversation and open the door for that conversation. Iris, since I have you, we did get a question through DM. It's about, actually, I thought it's a perfect question because it's a poster that we did not present in our Best of UEG, but it was recognized as an excellent poster during UEG. And it's about the safety and efficacy of multiple switches of biosimilar to infliximab. We have many patients now who are being switched from the infliximab original product to biosimilar, but now we have patients being switched from one biosimilar to another. And the concern is for both clinicians and patients, are we going to lose response? Are we putting our patient at high risk of developing antibody? So I know this poster was presented by Dr. Beatrice Gross, which is a fantastic human being and physician. So what are your thoughts about the findings, and what can we tell clinicians and patients with IBD about multiple biosimilar switches to infliximab?
So thank you for the question. First of all, I had the pleasure of chairing this session, so it's rather easy, despite the fact that we didn't present this poster, and it
I
was
saw the
actually an
pictures on
oral.
Twitter. So I was like, oh, they were in this.
No. Thank
Yes.
you so much. Yeah. So my
Power of social media.
my
Yes.
disclosure is that I chose it. I was one of the people who chose it as an excellent presentation, and because I think mainly, first of all, the question, right, a very practical clinical question, and the short answer that in that presentation the risk did not seem meaningful. What does that mean? That the duration of therapy, side effects, and there wasn't a signal for loss of response in patients that had a switch back. I will make, again, an asterisk, many asterisks here, actually. I remember the days a few years ago, right, when we said, oh my God, we're never going to switch. We're never going to do that. This is so dangerous. What about immunogenicity, loss of response? How can that be? This can be tested, and so on and so forth. So first of all, a few years later, you see, until now, I'll say more carefully, the signal doesn't look terrible, very worrisome, and so on. So patients, first of all, and physicians should feel quite safe when they're doing these switches. Okay, what we have to say, and it's not, again, it's in parentheses, no one, I think, is going to check, and if someone is checking, let me know, right, 13 or whatever number of biosimilars that we have. So you can't secure yourself and you can't be foolproof. However, it's unrealistic to think that someone will be taken from, I hope, during 13 biosimilars, right? So at the moment, we see that with a few biosimilars, for Adalimumab, for instance, which was what was tested, so you can go back and forth, and the signal doesn't look too worrisome. So patients, rest assured, nothing too terrible is expected to happen. And in several countries in the world, by the way, and we in Israel, in the beginning, were very careful, and we said we'll only switch. We do a one switch only when a patient is very stable. We had these rules, which I think are fine to make physicians and patients feel comfortable that someone is in control here. But after you do this and you think and you see that these switches are with a relatively favorable safety profile, then this is the era that we're going to be at. In the next few years, we're going to switch. And I don't expect at the moment that a significant safety signal is going to appear. We're not prophets, but that's what the data start showing us.
Thank you, Iris. I think that's very reassuring for a lot of us. And, fighting the insurance to keep somebody on either the original infliximab or the one biosimilar, it's becoming a futile effort. And I think, having this data is very reassuring in terms of, for both the clinicians and the physicians. And it sounds like, again, we're becoming more and more reasonable with time. The more we know, and that's the power of the data and the knowledge, is really to make our choices and our recommendation based on science, not just on anxiety and fear. Charlie, I want to get back to you. You presented the data on JAK inhibitor, correct? I didn't forget that.
Correct.
So you presented real-world data of TOFA and the final result from UEG looking at Upadacitinib as maintenance for UC. And, the results that we see in clinical trial, but also in real life, are very impressive with JAK inhibitors. I think we've all had patients who are really sick, whose disease did not respond to other therapies, and did extremely well with JAK inhibitor. With really, I think one of the things I've been impressed, in particularly with UPA, is the rapidity of response, and it's just such a relief for patients who have been sick for a while, and it's such a relief for us knowing that our patient is improving. So we had a couple of questions. One is, should we consider JAK inhibitor as first line? Right? So JAKs got dinged as, to be considered after failure or loss of response or intolerance to anti-TNF. But seeing the efficacy, the rapidity of onset, and really very impressive delta, like you showed us, between UPA and placebo in terms of induction and maintenance, should we start rethinking how we position JAK inhibitors?
So it's a really interesting question, isn't it? And one which we're all discussing at every IBD meeting at the moment for the reasons that you point out. So we're always looking, aren't we? We're looking at efficacy, we're looking at safety, and we're looking at durability. And actually that data to a certain extent was present in both the studies I presented, and certainly much more so in the Tofacitinib real world data, which extended for a very long time. Looking at the Tofacitinib first, there are some interesting messaging in there. Yes, it's a very effective drug. A lot of people did need dose escalation, probably more than we were aware of, but perhaps over 40% of those patients did end up on the higher dose longer term. The rapidity of upadacitinib has taken us all by surprise, really, because within days patients get better, don't they? Which is amazing to see. And it's an oral medication, it's well tolerated, and the safety signals to date, and that's with lots of real world data, are very good and do not seem, certainly in Tofacitinib, to look anything like the rheumatoid arthritis literature. So then we look at what groups we're going to use this in. I think it will be a drug we're using higher at the front of our treatment, certainly in ulcerative colitis, as we're seeing, because we have the data. I think the patient groups that we choose to do that in is a bit more challenging. And I don't think, for example, we have data, because I know there are questions on this. I don't think we have data, for example, on pregnancy. Well, we don't have data on pregnancy in younger, and therefore its use in younger women. I think it's a great drug to use in younger women up until the point where we get to discuss pregnancy, but we don't. That's always an issue we need to be considering. I think in the younger fit patients, it's definitely a choice and something we'll be doing more and more upfront for patients who want to take an oral medication which is fast acting. I'm not sure about older age groups yet. I think the data we've seen in the Tofacitinib was actually surprisingly good. 30% of their cohort had cardiovascular comorbidities, and yet we saw no increased signal in cardiovascular events in those patients, and no real increase in venous thromboembolism events either. So I'm really talking around the subjects and trying to avoid the actual question, aren't I, Aline? Which is, I do think we'll be using this earlier. Personally, in my clinical practice, I'm not confident enough to be using it first line as a medication in ulcerative colitis, because we have very effective treatments already. But I think this space will change in time. I think we'll be having this conversation a bit like we've just had about biosimilars later, and then we're saying, well, why weren't we using these drugs earlier? And that may well be the way we're talking in years to come.
Miguel?
Aline, make a very brief comment. So I agree with Charlie completely. The one in the United States, at least for those that are listening in the United States, based on the label and the FDA regulation, it is positioned after a TNF inhibitor failure, intolerance, or inadequate response. And to Charlie's point, that came about because of the oral tolerance data in rheumatoid arthritis patients 50 years or older with one cardiovascular risk factor at baseline. So when you look at that data and extrapolated even the Upadacitinib data, we're not seeing the problems that were reported in rheumatoid arthritis patients. So if today we were allowed to use it first line, just to put it, to maybe extend what Charlie said, I would use it first line in my ulcerative colitis patients, and maybe even in Crohn's when that becomes available. It's not available yet. But because of the label, that's really the only reason is the label at this point in my practice. Otherwise, I would use it first line.
I love it when everybody agrees around the world, right? So, or we all have the same dilemma, the same concern, but also similar opinions. That's fantastic. So, Charlie, you brought up a point of pregnancy, and that's one of the questions that was asked. If you have a patient, a young woman on JAK inhibitor, and she's planning to start a pregnancy, what recommendation would you make? And I don't want to put you on the spot, so maybe quickly, we only have 2 more minutes. I can have each one of you's opinion on what would you do in practice, and how would you manage that situation?
Okay, well, I'll be very quick. I'll be the conservative Englishman here. I think I have to tell my patient, I have to discuss it with them. They're very stable. They don't want to stop the drug, but I would have to say at this point, I really don't have data to support the safety of this particular medication. I have a lot of data, thankfully, to your colleagues in the States predominantly, and in Europe as well, to support the use of other medications. We can stop this medication. We can use it again afterwards, but for now, I can't recommend its use.
Iris?
Yeah, if a patient is planning pregnancy soon, so I don't see a huge point in starting that therapy, knowing that we want the most important thing is that she's in remission while she's conceiving, right? So I will not use it in a patient that is contemplating pregnancy 3 months from now. However, the fact that she's young does not mean she needs to be deprived of JAK inhibitors, right? So if no pregnancy is planned and if she's taking precautions, then for sure to induce remission and to maintain it with a JAK inhibitor, I think it's a reasonable thought at the moment, not if pregnancy is behind the door.
Miguel?
Short half-life, should be off of it for at least 1 month. Currently not using it in pregnancy. The piano registry may show that we can use it second, third trimester, but until those data become clear, probably wouldn't use it in pregnancy.
So you would switch your patient to a different therapy, make sure they're stable, and then.
Correct. But the half-life short enough that 1 month off of it before trying to conceive is sufficient. And then for now, either switch to something else. You could get into the argument, you actually wait, see how they do. If you need it in second trimester, which is not indicated right now, so have to be very careful for the audience, shouldn't use it in pregnancy, but some data may come out that second, third trimester, it's okay.
All right. Well, we're going to end on that. Thank you all so much. Dr. Dotan, Dr. Regueiro, Dr. Murray, thank you so much for doing this. It's been a fantastic experience between the webinar and the live Q&A. I want to give a special shout out to the team of Bonum CE and UEG for coordinating the schedules and the different time zone and getting us all together. And again, hopefully we can do this hopefully in person, or we do this experience on social media. It's been wonderful to learn from each one of you and to listen to your experience, expertise, and your take-home messages about this all the important abstract that were presented at UEG 2022. Thank you, everyone.
Thank you,
Aline. Thank you.
Thank you.
Bye-bye.
Thank you.